My name is Anthony Mato. I'm the director of the CLL program at Memorial Sloan Kettering Cancer Center. Today I'll be talking about BTK inhibitors in the management of chronic lymphocytic leukemia with a focus on how they should be incorporated into current clinical pathways for the management of CLL. These are my disclosures. I'll start by discussing our learning objectives. Number one, to describe strategies to integrate rapidly evolving data into CLL clinical pathways. Second, to explain the relationship between first and second generation BTK inhibitors and their off-target effects and toxicities. Third, to evaluate the potential role of BTK inhibitors in treating patients with CLL, including patients with CLL and COVID-19 infection, a timely topic. First, I'll start off by asking the question, how can pathways help in CLL? The initial goal of pathways were to promote efficient, best care while optimizing outcomes. Today's goal is a little bit different, is to achieve these stated objectives while controlling costs. To do so, things that we consider include efficacy, safety, and toxicity, as well as costs. We also have to weigh the pros and the cons associated with clinical pathways. The pros include our ability to manage drug utilization in a bundled payment world, avoid the need for time-consuming pre-authorization and appeals with payers, very important, capture stage and molecular data allowing for a more refined risk adjustment, and then pressure costly drug prices by explicitly accounting for price when efficacy and toxicity are similar. Well, what are the cons associated with pathways? We need data on administrative costs. We need to assure that there are clinical trials engagement in the development of pathways. We need to incorporate diagnostic methods. We need to minimize conflicts of interest when designing pathways, very important. Who's in charge of a pathway? Who governs a pathway? How are these pathways updated? Are they updated to account for differences in clinical trials and clinical practice? Are they updated to reflect the most recent approvals for drugs? This is an editorial that my colleague Chadi Naban, myself, and Bruce Feinberg put together in the American Journal of Hematology, specifically asking the question about clinical pathways in CLL. We've really entered into a unique time in the management of patients with chronic lymphocytic leukemia. We have several targeted agents approved between 2014 and the present, at least 6 agents. They have unique side effects, unique activity, and we're managing a disease that's a chronic disease where it becomes very important to decide how to optimally sequence these agents. There are several pathways that have been developed for the management of chronic lymphocytic leukemia, largely coming from experts who provide their consensus opinions, guideline statements, but what's noticeably lacking from the development of pathways are comparative clinical trials testing novel agents from one another and comparative data for adverse event profiles. Pathway design in CLL is an example where there's such a significant degree of complexity that needs to be considered. We need to think about core principles in designing pathways and argue that selecting the most effective therapy is always recommended first. However, when there are 2 therapies that appear to have similar efficacy, we want to try to make decisions based on which will spare patients more toxicity. And then if toxicity and efficacy are comparable, we need to think about making decisions based on costs. And while this may appear to be something quite simple, it's far from simple in the management of patients with CLL. I highlighted this earlier, but comparative trials of novel agents have not largely been conducted. That's a major issue when trying to make decisions based on efficacy. The same is true about comparisons of toxicity, and what we're learning over time is that the AE profiles of drugs, in particular BTK inhibitors, may be somewhat different in clinical trial patient populations as compared to patients treated in clinical practice or the so-called real world. So a proposal that we would make in the context of our editorial and for today's presentation is that building pathways in CLL must not only consider outcomes from clinical trials, but also incorporate data from clinical practice, both in terms of efficacy and toxicity, and also patient-reported outcomes. We need to think about gathering data from unique sources, such as real-world evidence, observational trials, and from patients themselves. We need to think about incorporating markers of prognosis. Not all CLL is the same from a molecular genetic profile, and there's certainly evolving literature to support individual decisions for patients from a treatment perspective based on their prognostic profiles. And then, of course, calculation of cost is far from simple. We need to think about patients in the decision model. We need to balance costs with outcomes, and we need to make sure that that's directly involving patient engagement. It's not only about the cost to a payer, but it's also about the cost to individual patients. So there is an urgent need for clinical pathways in CLL, and some things that I would highlight that are very important include engaging all stakeholders in the decision process, understanding various value-based utility differences from a patient perspective. We need to consider, again, real-world registries. These pathways need to have an algorithm to be updated because the field is evolving so quickly, and pathways must be designed and maintained with scientific rigor that incorporates the needs of all stakeholders. I'll now delve into BTK inhibitors specifically and talk about how pathways might help. BTK is a key mediator of B-cell receptor signaling in B-cell malignancies, particularly chronic lymphocytic leukemia. I think we would all agree that Ibrutinib has transformed the treatment of CLL. Here, I've highlighted some of the key landmark clinical trials leading to the approval of Ibrutinib across CLL in the frontline and relapse refractory settings. The goal of such therapy is durable disease control with continuous oral therapy and minimal toxicities for patients. Well, things are changing pretty rapidly in CLL, and now we have more than one BTK inhibitor approved. Ibrutinib is approved frontline and in the relapse refractory setting, as is Acalabrutinib, and maybe Zanubrutinib is on the way. All of these are irreversible BTK inhibitors. We need to decide how do we find the right initial treatment for patients with CLL, and let's start there. These are long-term follow-up data for Ibrutinib as a monotherapy for the management of CLL. These are data that were presented previously by Dr. John Bird, and the data are quite impressive. 7-year progression-free survival from this patient population in the frontline setting is 83%. You're looking at 7-year overall survival of 84%, and numbers are also quite impressive in the relapse refractory setting, given that this is a very heavily pretreated patient population. Of course, differences occur by chromosomal abnormality, and patients with deletion 17p, particularly in the relapse refractory setting, likely have worse outcomes. These are longer-term follow-up data from the frontline RESONATE-2 trial comparing Ibrutinib as compared to chlorambucil. Here again, we see excellent progression-free survival, including in patients with traditional poor risk features like unmutated IGHV and deletion 11q, as well as improvement in safety profile over time. Most of the discontinuations occur relatively early. Here we see data stratified again by prognostic features. Here we see outcomes stratified by deletion 11q status and by IGHV status. The takeaway from this slide is that traditional poor risk features associated with CLL in the era of chemoimmunotherapy are no longer necessarily the case. Patients with unmutated IGHV and deletion 11q can do quite well with targeted therapies. A more recent trial has compared the combination of Ibrutinib with rituximab as compared to FCR, a clinically relevant control for patients who are young and fit. The take-home from this trial was that Ibrutinib plus rituximab was better than FCR from the perspective of progression-free survival, but a little bit of a surprise with early follow-up was that it was better in terms of overall survival as well. So here we have an example of a BTK inhibitor-based therapy beating a standard of care, which is quite relevant for younger fit patients. Also, the combination of Ibrutinib with or without rituximab has been compared to bendamustine rituximab. This is the Alliance AL4-1202 frontline trial, and the take-home here was that Ibrutinib-based therapy with or without rituximab was better than bendamustine rituximab in terms of progression-free survival, but no clinically significant difference in terms of overall survival, and outcomes were similar for IGHV mutated patients, but the benefit of the BTK inhibitor was most pronounced in the IGHV unmutated patient population. I'd next like to focus on the Illuminate trial. This is the combination of Ibrutinib with obinutuzumab as first therapy compared to the CLL-11 regimen of chlorambucil plus obinutuzumab. These are longer-term follow-up data, and you can see here the progression-free survival at 30 months was 79%, also quite impressive, which has led to the approval of Ibrutinib with obinutuzumab as a first therapy for managing patients with CLL. While BTK inhibitor with or without an anti-CD20 is already an FDA-approved approach, what about combining BTK inhibitors with other novel agents? These are data quite impressive from the MD Anderson Cancer Center looking at the combination of Venetoclax and Ibrutinib in the front line. And the take-home data that we have from this trial, as per the initial publication in the New England Journal of Medicine, is that it's quite active. At 12 cycles of the novel combination, 88% have had a CR or a CRI, 61% had a remission with undetectable minimal residual disease. The combination appeared to be tolerated quite well, and this combination is now in randomized trials for the frontline setting and is also being studied in the relapse refractory setting. Well, what about what's going on in clinical practice, the so-called real world? These are data that our group published on 616 patients treated with Ibrutinib, largely in the relapse refractory setting, trying to understand if the outcomes, both from a perspective of efficacy, but also from tolerability, were similar between what's going on in practice and what's going on in clinical trials. The take-home from this particular observational study was that toxicity was the most common reason for discontinuing Ibrutinib in the frontline and in the relapse refractory setting, followed by CLL progression, followed by other causes, including Richter's transformation. The discontinuation rate in the relapse refractory setting was initially somewhat higher than what had been observed in the clinical trial setting. And so this has really led us to appreciate the value of real-world evidence and that we can learn about unique toxicities, reasons for discontinuation and how they may differ from clinical practice, and overall discontinuation rates, and how those may impact efficacy. Well, now let's think about alternative BTK inhibitors, and I'll focus on Acalabrutinib. This is a second-generation covalent BTK inhibitor, which is highly selective, and you can see from the kinome maps for both Ibrutinib versus Acalabrutinib that there are less off-target effects for Acalabrutinib as compared to Ibrutinib. Does this translate into any differences in efficacy? Well, these are again data presented by John Bird, looking at Acalabrutinib in the frontline setting. And here you can see, with relatively long follow-up, 89% of patients are continuing Acalabrutinib at 42 months, with the best overall response rate of 97%, and responses are fast. Median time to first response is 3.7 months. Well, Acalabrutinib has been studied in randomized trials as well, and this is the Elevate-TN trial, which randomized the combination of Acala with or without obinutuzumab versus chlorambucil plus obinutuzumab, was overwhelmingly positive for the Acalabrutinib-based therapy. PFS at 24 months was 93% for the combo versus 87% for the mono versus 47% for the control, which has led to the approval of Acala with or without obinutuzumab in the frontline setting. These are data that were presented by the Dana-Farber group, which I won't go into great detail, also looking at novel combination therapy with Acalabrutinib, Venetoclax, and obinutuzumab, the AVO regimen. And here you can see that this is a highly active combination where there's a high proportion of patients, 100%, having a response by cycle 16. Well, what's the adverse event profile for Acalabrutinib? Here we list data from nearly 610 patients focusing on non-hematologic toxicities or AEs, non-hematologic AEs of clinical interest. You can see here what's most noticeable is the absence of certain toxicities from this list, including atrial fibrillation, a very low proportion of major hemorrhage, a relatively low proportion of hypertension, and so possibly a signal that this BTK inhibitor might have a different or distinguished AE profile from Ibrutinib. Of course, head-to-head comparison is not yet available, and comparing clinical trials is not really the best way to determine the AE profile of one drug as compared to another. Acalabrutinib has also been studied in Ibrutinib-intolerant patients. These are data by Farouk Awan, which have focused on Acala in an Ibrutinib intolerant population. Kerry Rogers has also done a larger trial. And the take home here was that Acala did appear to be well tolerated and efficacious in this population, where 70% remained on Acalabrutinib after a median of 19 months, and 72% of patients did not have recurrence of their prior Ibrutinib-associated AE. Let's take it one step further and look at Zanubrutinib, which is a highly selective BTK inhibitor. And we have data most recently presented at the ASH meeting in 2019, looking at Zanu in the frontline and relapse refractory settings, which again appears to be a quite active agent in a poor risk patients with CLL. There were data published today in Hematologica looking at Zanubrutinib in patients who had deletion 17p in the frontline setting. Zanubrutinib has also been studied in novel combinations. This is presented by Jake Somerai from Mass General, looking at the combination of Zanubrutinib, obinutuzumab, and Venetoclax in the frontline setting. And again, here, similar to the AVO data, quite active in terms of overall response rate, with a high proportion of patients who achieve undetectable residual disease, 73% in the marrow, 83.8% in the peripheral blood. This is a pooled safety analysis presented by CONTAM, looking at the AE profile of Zanubrutinib. And here you can see some similar, very similar to what I presented earlier for acalabrutinib, but again, head-to-head comparative data versus Ibrutinib is not yet available, so we're forced to make cross-trial comparisons and also look at data once it's available from the real-world setting. Well, I mentioned earlier that the BTK inhibitor floodgates have opened for irreversible inhibitors. What about reversible inhibitors? There are several non-covalently binding BTK inhibitors that are currently being studied, which may have distinguishable adverse event profiles, but more importantly, may be able to overcome resistance associated with the CYS481 mutations, which have been noted in patients treated with Ibrutinib and acalabrutinib thus far. This is a slide and data presented by the OSU group, particularly Jennifer Woyak, looking at the limits of covalent BTK inhibitors. The major issues continue to be resistance, largely mediated by CYS481 mutations, and intolerance leading to discontinuation of what should be a continuous therapy. This is the molecule ARC-531, which is a non-covalent BTK inhibitor, which was studied in high-risk relapse refractory CLL, including patients with the CYS481 mutation. These were data presented at the ASH meeting by Jennifer Woyak. 9 patients included here in this waterfall plot, but you can see that 8 of the 9 patients had a response with a greater than 50% reduction in lymphadenopathy, and there were even some responses noted in patients with Richter's transformation. This is the LOXO-305 molecule, which is being studied in the phase 1 Bruin trial in CLL and other B-cell malignancies. I presented these data at the most recent ASH meeting. The molecule appeared to be quite well tolerated, as you can see from the AE table of 28 patients. No grade 3-4 toxicities, no DLTs, and no MTDs were noted. Let's talk about the application to clinical practice. Strategies for selecting the optimal BTK inhibitor, which speaks directly to what I started with earlier regarding the development of pathways. There are currently 2 BTK inhibitors approved in CLL, SLL, Ibrutinib with or without a CD20 antibody, Acala with or without obinutuzumab. What are some of the data in favor of Ibrutinib? Well, we have longer-term follow-up now up to 8 years. There is a robust portfolio of phase 3 studies comparing it against clinically relevant controls, including FCR and BR. And we have more data in del17p, TP53 mutant patients. Well, what's in favor of acalabrutinib? There's potentially an improved safety profile. The data are compelling thus far, both in terms of non-serious side effects and possibly cardiac events. We believe there's comparable efficacy data to Ibrutinib, though the follow-up is shorter and we have no head-to-head data. And we have some positive head-to-head data versus more robust comparators in the relapse refractory setting. I didn't include it here, but acalabrutinib has been compared to Idelalisib or rituximab in the relapse refractory setting, and that was a positive trial. And then, of course, we can delve a little bit into how do we decide whether we give BTK inhibitors as a monotherapy or in combination. In the case of Ibrutinib, when we're thinking about CD20 antibodies, we have no PFS benefit for rituximab from the randomized trials thus far, although you might think about adding a CD20 with immune-mediated cytopenias. And there's an unknown PFS benefit for OBIN because the Illuminate trial did not include an Ibrutinib monotherapy control. In acalabrutinib, we know we have a PFS benefit for OVIN from the Elevate-TN trial versus acalamono, but no clear overall survival benefit. So the pros and cons need to be discussed with individual patients. So the conclusions when we think about BTK inhibitors in the frontline setting, they are now a mainstay of therapy in the frontline treatment of CLL. Up to 20% of patients can discontinue them early, particularly we have more data on Ibrutinib in clinical trials, but we need more real-world evidence, and certainly the DC rates appear higher from the real-world data. Next-gen BTK inhibitors appear to have similar efficacy as Ibrutinib without head-to-head comparative data, possibly greater tolerability. The newer agents may be associated with reductions in BTK inhibitor-associated toxicities like cardiac and bleeding complications, skin toxicity, and arthralgias. But again, head-to-head data would be most useful, and more real-world evidence from next-generation BTK inhibitors would be more useful. And then the reversible BTK inhibitors are in development. None are approved, but there is compelling early data to suggest that they may overcome resistance mutations. The next part of the talk, I'm going to delve into finding the right initial treatment for patients with CLL. We have several novel targeted therapies available in the relapse refractory setting. These include BTK inhibitors, Acala and Ibrutinib, Venetoclax with rituximab or as monotherapy, and 2 PI3K inhibitors currently approved. Here it's even more complicated when we're thinking about how to incorporate BTK inhibitors into pathways. We need to consider prior therapy. We need to consider reasons for discontinuation, and we need to consider the levels of evidence of the data that we're using to incorporate it into a pathway. This is the ASCEND trial, which I mentioned earlier, which compared Acalabrutinib versus Idelalisib or bendamustine Rituxan, relapse refractory patient population, overwhelmingly positive for Acala, and this is the first randomized head-to-head comparison of novel agent versus novel agent, favoring BTK inhibitors over PI3K inhibitors. These are compelling data presented by my colleague Toby Ayer, looking at real-world data for Venetoclax versus Ibrutinib. Small numbers, but some compelling data that Venetoclax may precede Ibrutinib in the relapse refractory setting. But my summary when trying to make clinical decisions is that in all circumstances when clinically acceptable, data support use of a BTK inhibitor or Venetoclax before a PI3K inhibitor, but no definitive data to help us identify whether Venetoclax or a BTK inhibitor should come first, either in the frontline or relapse refractory setting. Another major question when we're designing pathways is thinking about sequencing of therapies. Should my BCL2 inhibitor precede BTK or the opposite sequence? BTK inhibitor treated patients are somewhat unique. A significant proportion of patients are currently treated in the US on BTK inhibitors, both in the frontline and relapse refractory settings. We need to think about reasons for discontinuation, how they impact selection of next therapy, and think about the level of evidence for data supporting sequencing of novel agents. How do we manage patients on BTK inhibitors in a community setting? Let's first delve into Ibrutinib discontinuations. These are data we presented from real-world data set looking at Ibrutinib in the front line. We're comparing that to the RESONATE-2 patient population, where initially the discontinuation rate for Ibrutinib was 12.5%, and our real-world data said it was up to 24%. With longer-term follow-up from the same clinical trial, the RESONATE-2, we've now learned that the discontinuation rate for Ibrutinib is 41% at 5 years. And so here we see a great example of where the real-world data and the clinical trial data are coming together. These are 3 clinical trials presented by Stephen Coutre, looking at Ibrutinib in the frontline and relapse refractory settings. So these are clinical trial patients, and with longer-term follow-up, we see that the discontinuation rate for Ibrutinib is actually 38% in these pivotal trials, with resistance and adverse event being the most common reasons for discontinuation. So I've highlighted here the most common reasons as stated: AE, progression of disease due to CLL, and progression of disease due to transformation. Again, highlighting more data from the real world, which can be helpful in terms of thinking about AE profile. These are 2 papers that we published on Ibrutinib, where you can see toxicity was the most common reason for Ibrutinib discontinuation in the frontline and relapse refractory setting, and the most common reasons for discontinuation included AFib, infection, hematologic events, bleeding, and pneumonitis. Well, now I'll talk a little bit more about Acalabrutinib, and does the use of this more selective BTK inhibitor solve the issues of intolerance and/or resistance? These are data presented by John Bird, looking at Acalabrutinib in the relapse refractory setting. And one thing to highlight, and I think probably the best way to judge the AE profile of any of these drugs, is that only 17 patients discontinued Acalabrutinib due to an adverse event. Very important to note that adverse events are not leading to discontinuations using this agent. Here we see the AE profile for Acalabrutinib in the relapse refractory setting in the trial that I previously mentioned, and here the discontinuation rate for Acalabrutinib in the relapse refractory setting due to adverse event was only 11%. Well, how do the reasons for discontinuation and prior therapies influence outcomes of next therapies? This is a real-world study where we tried to look at next therapies following either Ibrutinib or Idelalisib discontinuation, and we learned several lessons. There's no clear role for chemotherapy in heavily pretreated patients who are failing Ibrutinib. Venetoclax was probably a better agent over Idelalisib in Ibrutinib-resistant patients. And then finally, you can think about using an alternative kinase inhibitor, for example, going from Ibrutinib to acalabrutinib in the setting of an intolerance event. Finally, I want to talk a little bit more about sequencing data for BTK followed by Venetoclax, or Venetoclax followed by BTK inhibitors. These are data presented by Jeff Jones looking at Venetoclax following use of a BTK inhibitor. Overall response rate was 65%. Remissions were quite durable with a median PFS of approximately 24 months. These are the Acala intolerant data that I previously mentioned presented by Kerry Rogers. Looks to be quite tolerable with 12% discontinuation rate due to adverse events. And then finally, data on BTK use after Venetoclax-based therapies. And these are data that our group has prepared looking at BTK inhibitors after Venetoclax, specifically in a BTK naive patient population where the median PFS was 32 months. So takeaway messages as we build pathways include, again, remember prior exposures, reasons for discontinuation, and the resistance profile, which may be quite relevant in the near future. And then keep in mind randomized trials are lacking. And then this is a schematic that I put together specifically focusing on Venetoclax discontinuation, again, thinking about those same common ideas: prior exposure, reasons for discontinuation, and the resistance profile. Finally, I'll touch on a timely topic: BTK inhibitors for treating COVID-19 associated respiratory complications. This is data that have been presented by Steve Treon, which is a model of BTK-dependent hyperinflammation in severe COVID-19. The hypothesis here is that if you inhibit BTK, you can shift the immune response, particularly activated macrophages, to a more tolerant form, and that more tolerant macrophage profile may lead to decreased hyperinflammation in the lungs, decreased scarring, and minimize the risk of the hyperinflammatory state associated with lung damage related to COVID-19. Well, do we have data yet to support using BTK inhibitors in COVID-19? I would say they're extremely limited at this time. This is a brief report published in Blood for 6 patients receiving Ibrutinib who were diagnosed with COVID-19 with a hint that outcomes may be improved. This is also additional data looking at off-label use of acalabrutinib with severe COVID-19 published in Science Immunology, where there was also, in this slightly larger patient population, a hint that acalabrutinib may be improving outcomes. Of course, use of BTK inhibitors is not the standard of care for managing COVID-19, but I will highlight there are 3 randomized clinical trials looking at Ibrutinib, acalabrutinib, and Zanubrutinib versus placebo in COVID-19 positive patients with severe disease, which may provide us with insight about whether or not that class of molecules can in fact blunt the hyperinflammation associated with COVID. And with that, I'll stop, and I thank you for your attention.
Hi, we're here with Dr. Anthony Mado to answer some audience questions. Dr. Mado, the first question from the audience is this one. Would AFib and hypertension be managed the same way for acalabrutinib, the way other patients are managed in the same condition in primary care?
That's a really good question, and thanks so much for everybody for listening to my presentation. The short answer is yes. We don't really think that there are specific strategies for managing hypertension or AFib as a result of exposure to a BTK inhibitor. The one difference may be, or certainly is, that we don't use warfarin in combination with BTK inhibitors because of a potentially increased risk of bleeding. But other anticoagulants or aspirin could be used as needed, as are agents for rate and rhythm control. The same is true for hypertension, with the caveat that we should not be using agents that interact with CYP3A4 metabolism, because both drugs go through the same metabolic pathway. So like diltiazem, for example, would interact with acalabrutinib. There's a lot more data that are needed to look at management of cardiac manifestations of these agents, but at this point, you follow standard recommendations.
Great, thank you. What are the situations where Venetoclax would be used before a BTK inhibitor in first-line CLL?
Good question. That's a tough question to answer because of the fact that there is no head-to-head comparative data yet available in the frontline setting. So that's something that we need to keep in mind. The main advantage of using Venetoclax over all BTK inhibitor-based therapies is that it's a time-limited therapy. So the way that it was designed was that it's given for 12 months in combination with Oben or obinutuzumab. All BTK inhibitors, whether they're given alone or with a CD20 antibody, have to be given in a continuous strategy. I'm not saying that's actually what has to be done, but that's the way they were studied, that's the way that they're labeled, and that's the way that we use it in practice. I think a limitation in the prior design of or development of BTK inhibitors is that they're mandated to be continuous therapies, but we do generally follow the way that they're given in the context of the prior clinical trials that led to their approvals.
Great, thank you. If Ibrutinib and Venetoclax are now being considered for frontline from clinical trials, would myelosuppression and serious infections be a limitation of this trial? Or would you utilize growth factors and steroids the way you would for similar IO medications?
Yeah, so I'm not a huge fan of combining novel agents together at this point, like Ibrutinib and Venetoclax, if if they aren't studied in a way that makes sense to me. And currently, we have data from MD Anderson for the combination without comparison. We have the Captivate trial, which has provided us very minimal data in terms of the long-term clinical benefit. And then we have a randomized trial of the combination versus obinutuzumab with chlorambucil, which both agents have independently beat as a control arm. So I don't consider that a clinically relevant control. So until someone can design a trial in high-risk patients where we think we need this level of combination, or we're able to provide them for a shorter duration than the prior fixed duration schedules like the Ven-Oben, or someone can tell me that they're leading to cure for patients, I think that the risks outweigh the benefits and they won't be a standard of care for me.
Okay. And we did have a question about that combination that you were just referring to. What about Venetoclax and obinutuzumab in the first line setting? The comment is one advantage is fixed duration of treatment. You can comment on that?
That is true. That is the only novel agent-based therapy that's approved in the U.S. in the frontline setting that is a scheduled fixed duration of 12 months. All of the other novel agent-based Ibrutinib, acalabrutinib schedules are continuous therapies. So that is an advantage.
Great, thank you. How do you decide on the use of a BTK inhibitor over Venetoclax without comparative data?
That's a tough question. It becomes a longer conversation with patients than would need be if there were comparative data. But the way to do it is to, first of all, recognize that they're both very active, efficacious agents. The second is that each provides something different. Venetoclax is time limited, yes, but it's a ramp up that can be somewhat difficult. It requires combination therapy, and we don't have really long-term follow-up. Ibrutinib or acalabrutinib are relatively easy to start. Their activity look good whether you give them alone or in combination. With Ibrutinib, you have some long-term follow-up data, which is nice to be able to quote to patients who really want a drug that has a long track record. With acalabrutinib, we have some modest follow-up data up to 48 months. And we also have a great AE profile that is very attractive to people as well. So it's a conversation that focuses on the advantages and disadvantages and acknowledges that the appropriate trials comparing these drugs have not been conducted yet.
Okay. Are there situations where you favor the use of Ibrutinib over acalabrutinib?
That's a good question. So there are a few unique toxicities of acalabrutinib that should be highlighted. One is headache, which seems to occur relatively early on in the course, is generally mild to moderate and self-limited over the first 1 to 2 months of therapies. But if I had a patient who already had severe headaches, migraines, cluster headaches, something that were already debilitating and somewhat frequent, I would probably go with Ibrutinib over acalabrutinib. The other example may be somebody with severe gastroesophageal reflux that requires a PPI. You can't give acalabrutinib if a patient is on a PPI, no matter how they're spaced. And so if I had a patient with severe GERD or esophagitis or it's a couple of examples, or peptic ulcer, for example, that required acid suppression with a PPI, I would probably favor Ibrutinib. So that's just 2 examples I can think of.
Okay. Looks like we have time for one more question. Is there a major flaw in the development of BTK inhibitors that you can discuss?
I think the major flaw that I would highlight is the fact that they've only been a couple different things, but they've only been designed, particularly in the frontline setting, to be continuous therapies. And we saw a hint of data presented last year at the ASH meeting by Tate Schoenfeld, where they looked at patients who got a median of 15 months of Ibrutinib with rituximab on the ECOG 1912, and then had to come off for some reason besides progression. And they got an average of another 24 months of progression-free survival. And so that really speaks to the fact that while BTK inhibitors were designed to be continuous therapies, there should have been trials looking at either MRD-based therapy, MRD-driven decision-making, or a fixed duration schedule to allow patients sort of an on-off strategy. And I think that that's what's gotten Venetoclax the most amount of attention and the biggest gap in the development of BTK inhibitors.
Great. Thank you, Dr. Mado.